Hello, everyone. Welcome to our Learn at Home series. Today, I have Dr. Lindsey Gurin with us. Dr. Gurin is an assistant professor of neurology, psychiatry, and rehabilitation medicine at NYU Grossman School of Medicine, and she is the program director of the NYU Combined Psychiatry Neurology Residency and director of behavioral neurology at NYU Langone's Orthopedic Hospital. And there, she provides cognitive neurology and neuropsychiatry consultations to the Rusk Acute Inpatient Brain Injury Rehabilitation Unit. Dr. Gurin has published on neuropsychiatric disorders associated with acquired brain injury, disorders of consciousness, and catatonia in patients with neurological disorders. So that's just a brief bio for Dr. Gurin, and now I will turn it over to her, and she will give a presentation on the facts of brain injury and TBI.
Great. Thank you so much. And thank you for having me here today. You guys hear me okay? Yes. Right. So I'm excited to be here and talking about brain injury, traumatic brain injury. I used to see patients at Pearl Barlow. And before that, I did my neuropsychiatry residency, combined residency in psychiatry and neurology. And the way I got into that actually was that in medical school, I was kind of placed in a clinic for people with brain injuries who were coming back from Iraq and Afghanistan at that time from at the VA where I was in medical school. And so, sort of saw at that point that, there can be these difficult neuropsychiatric symptoms that happen with traumatic brain injury. And then during my time at Pearl Barlow and working with the ADRC, many of these symptoms also can happen with dementias as well and cognitive disorders of all types. And so, today I thought I would cover just kind of some of the basic broad strokes of traumatic brain injury. We'll go into a little bit of history. But then, I'm kind of curious to know if anybody has any questions or thoughts about this, or if anyone has had kind of personal experiences with this stuff, we can spend some of the time talking about that. So let's see. Yeah, just an overview. So I'll go into some of the brief history of traumatic brain injury, and then we'll talk about, for me as a neuropsychiatrist, some of the things that I'm thinking about and the sort of connection between these two syndromes. So just kind of to start, why are we here? Why are you having a neuropsychiatrist talk to you about TBI? I think many of you are enrolled as ADRC participants. Thank you for doing that. This is we're thinking about sort of the larger view of neurologic disorders and the burden that these place on, all of us, our loved ones and people who are living with this and in society generally. And this is from a 2017 paper that looked at the burden of neurological disease kind of in economic terms in the US and found that the annual cost to US society of these kind of 9 common neurological disorders, so including Alzheimer's, low back pain, stroke, TBI, migraine, headache, epilepsy, spinal cord injury, and Parkinson's, that collectively these disorders cost us $800 billion a year. And so Alzheimer's and related dementias account for about 30% of that. You could see down here at the bottom, AD and other dementias, so about 7.5 million people prevalence. So that's kind of at any given point, there's about 7.5 million people living with these illnesses, and it's going up every year. And the estimated cost of this alone is about $243 billion. For TBI, the kind of estimated annual incidence, so the number of people every year who suffer a TBI is about 1.4 to 1.7 million. And collectively, sort of cumulatively, 3.2 million people end up on long-term disability. And the cost of this is estimated to be about $86 billion. And what's important to think about is actually these problems are not independent of each other. And so we'll talk a little bit about this, but thinking about how to approach both of them, it can be helpful, kind of sort of strategies that are targeted at one can be helpful for the other one. And again, as I said, for me as a neuropsychiatrist, this is a lot of what I see people with both TBI and also dementia who may have neuropsychiatric symptoms. So these are problems with mood, thinking, behavior, sort of changes in personality. And these symptoms often are very hard to manage. There are not medications that are designed for them. They're not really therapies that are always, sort of super effective. And so the neuropsychiatric symptom burden of these illnesses can be quite high and often is believed to account for a lot of the economic and the social and psychological burden of living with these illnesses. So just some definitions. So thinking about brain injury, TBI, and dementia. So acquired brain injury is a term, a general term that refers to just damage to the brain that occurs after birth. Traumatic brain injury, and that can be traumatic or non-traumatic. Traumatic brain injury specifically is damage to the brain, or kind of more specifically than that, alteration of brain function or other evidence of brain pathology that's caused by an external physical force. And so that definition, there's been kind of a lot of discussion of that, especially I'll get into a little bit later. So, stuff in the news and thinking about milder traumatic brain injuries and how do we define it. You can have a head injury with no brain injury. So that would be if you sort of, something impacts your head, but you don't have any neurological symptoms. So really to have a TBI, and that includes at the milder end, concussion, which is a synonym for mild TBI. To have a TBI, you really need to have at least one symptom of kind of brain disturbance, like me feeling dazed after the injury, or sort of seeing stars, kind of feeling off balance for a little bit. So we need to have kind of one of those, and it tells us that something did happen to the brain with this injury. The other type of acquired brain injury is a non-traumatic brain injury, and so this is basically anything that isn't trauma. And so examples of this are stroke, ischemic or hemorrhagic stroke, having low oxygen to the brain. This can happen if the heart stops or if people stop breathing for another reason. Brain tumors or surgeries for brain tumors or epilepsy can cause this injury sometimes. Demyelinating disease like MS, multiple sclerosis, and other kind of inflammatory and encephalitis type illnesses as well. So there are kind of a whole range of things that can do this, that can kind of interrupt the normal function of our brain. And then, dementia, we use this term a lot, and there's obviously sort of, many kind of contexts for this, but the general meaning of this is dementia refers to cognitive impairment that is severe enough to interfere with activities of daily living, right? So you can have cognitive symptoms going on, but be able to do your daily life. We wouldn't call that dementia. And so to have a diagnosis of dementia, there is, at least one cognitive problem that is significant enough that's interfering with kind of living independently, but it is non-specific as to the underlying cause. And so, the sort of technical term now, we say major neurocognitive disorder, which is the same as dementia. You need to specify what it is from, and so that can be from stroke. We call that vascular dementia. Very common ones we'll talk about are neurodegenerative dementia, so Alzheimer's disease, from temporal lobar degeneration and Lewy body pathology among those. You can also have a dementia due to traumatic brain injury, and that would be, typically the historical meaning of that has been when you have an injury that has caused pretty significant damage, and you end up with severe cognitive impairments that do meet this criteria. As we'll talk about, there are kind of other pathways to this as well. But so again, that kind of, there are these types of injuries that we're talking about, and then there is the sort of general, kind of the more description of the level of cognitive problems that somebody might be having. And so just, it's kind of this is a broad strokes sort of discussion here, but the kind of link, what's the relationship between traumatic brain injury and dementia? And so, we know that cognitive impairment is actually a risk factor for TBI. And this is true all across the lifespan. So in younger people, attention deficit disorder, ADHD, as a risk factor for traumatic brain injury, and that is related to, people moving through the world and maybe not noticing things that are dangerous or sort of, getting injured. We know adults with ADHD generally do have higher rates of accidental injury. And so TBI is one of those accidents. And so that is kind of one example. And then on the other end, sort of as people are getting older, cognitive impairments due to aging or due to Alzheimer's dementia or other types of dementias can increase risk of things happening that cause TBI. At the same time, TBI is a risk factor for all-cause dementia. And so TBI has been described as the strongest environmental risk factor for Alzheimer's dementia. And there is, again, there's sort of the data on this is kind of interesting because the research sort of pools and sort of like the researchers who are looking at these topics, both dementia and TBI, are pretty siloed. And so the people who study Alzheimer's dementia are not really the people studying traumatic brain injury. And so the different sort of measurements and scales and symptoms that people are following are really not always parallel across different studies, and so it can be hard to compare. But sort of historically, the idea with traumatic brain injury was really that you had this thing happen to you, and perhaps you have symptoms afterward, but is this, a fixed injury. And now we think about traumatic brain injury really as a chronic lifelong condition, and then some people can involve chronic inflammation and possibly chronic neurodegeneration. And so they're, having had a traumatic brain injury, depending on the severity at the time, that puts you at risk of potentially having a TBI-related dementia at that time, or possibly over time developing progressive cognitive decline. The studies that we do have that kind of have looked at the links between these two do show that it appears that people who have had a traumatic brain injury are at risk. Not everybody will develop this, but are at risk for developing dementias at earlier ages. And there are many other factors that go into this too. But that on average, the age of onset may be a little bit earlier in people who are going to develop a dementia. And that it may be sort of more likely to involve certain other kinds of neurobehavioral symptoms, which we'll talk about. But the important thing here, so, it's a sort of bidirectional relationship between these two, but the important thing here is actually that the same interventions for both can be helpful. And so, we'll kind of cover this, I'll come back to this, but healthy lifestyle choices and making sure you're connected with medical care, especially if you're living with at least one of these diagnoses, sort of attending to symptoms. And, I find as a neuropsychiatrist, people are often reluctant to talk about mental health symptoms, and it's like stigmatizing. It's very hard, to sort of seek help for this kind of thing, but actually getting help for this can really overall help you both feel better, or your loved one feel better, but also can reduce your risk of developing other complications of the problem down the line. So I was going to do this as like a little quiz, but I feel like, I don't know if we probably can't do it as a chat. So I'll just show, this is actually from a lecture that these two slides are from a lecture that I give to medical students about traumatic brain injury. And so the question here is, in traumatic brain injury, I'm going to move this out of the way here. Traumatic brain injury, which of the following signs or symptoms is most likely to persist and interfere with rehab? And so the options here are A, memory loss, motor deficit, altered personality, sensory deficit, or language dysfunction. And since this is a webinar panel, I think you guys can answer.
I can help you with the chat if you like.
Yeah.
If anyone wants to guess in the chat.
Put something in the chat. If you guys are ready for your neurology boards.
Or if anyone would like to talk, you can as well.
Okay, I
Or
may
raise your hand and I will allow you to talk. Otherwise, we can just give the answer away.
Yeah, I only got one of these multiple choice questions because after I made it, I was like, I don't know if I'll be able to do it. So it's okay. I can just give the answer away. Yeah.
Nothing in the chat, so you can give the answer away.
So the answer is altered personality, C. And when I do this with medical students, we always get a range of different answers, because all of the things that were there, I'll just kind of show you again. I don't know if I can go back. Yes. These are all actually things that can happen after traumatic brain injury. They can interfere with rehab. So you can have memory problems. You can have problems with movement, motor deficit. You can have difficulty with sensation and language dysfunction, especially, depending on where the injury is. We know that usually most people, the left hemisphere is dominant for language. And so if you have injury to the left frontal or left temporal region, sometimes you can have language problems after a traumatic brain injury. What ends up being kind of the most significant and the most really problematic for people and their families and for people taking care of them are the personality, kind of quote unquote personality changes. Everything else is present, but it's really kind of becomes less significant in this syndrome. So I just kind of think the history is a little bit interesting. So we'll go through this. I don't know if anyone is familiar with this man. I've got the answer here, but Phineas Gage. So he is, he's called here neuroscience's most famous patient. So this is someone who let's say I forget the year, 1860, 1848, here we go, was a young guy working on a railroad, and there was an explosion, and this rod, you can see him kind of posing with it here, went actually through his head, sort of through his cheek and then out his eye. and kind of completely exited. I have this like this. I also show this to the medical students. There is a like, if you're interested in this story, after I'm done telling it, there is a stop action Lego video of this on YouTube that you can watch. It's made by like an AP psychology high school class that I just think is like so good, set to music. They did a great job. So some of these shots are from the Lego reenactment of this story. But so you can see Phineas Gage here. And so, yes, he had this terrible accident. You can see his skull is on display. I think this is the Medical Museum in Philadelphia. You see the hole that the rod made. And so, when the story is told now, people kind of recall Phineas Gage as this like, sort of he had these changes, which we'll talk about. But at the time, this was felt to be, this guy's a medical miracle. Like he had this rod go through his head. He actually got up and walked to the doctor. After the injury, was blind in his left eye and had some left facial weakness, but he otherwise had a, sort of normal neurological exam. He could move everything. He was able to count and talk. But he couldn't go back to work. So instead, he kind of made a career touring as a medical marvel. He eventually moved to Chile to drive stagecoaches. He died in 1860 because he had epilepsy and died with uncontrolled seizures. And so it was really only after that happened that his doctor then published on these behavioral changes that they had observed in him after the accident. And so some of the quotes from that he was found to be exceedingly capricious and childlike, with a will as indomitable as ever, will not yield to restraint when it conflicts with his desires. He was devising many plans of future operations, which are no sooner arranged than they are abandoned. He was fitful, irreverent, indulging at times in the grossest profanity. His mind was radically changed, so decidedly that his friends and his acquaintances said he was no longer Gage. So it's obviously a very significant change in how this person was being perceived by people around him, sort of the way that he was comporting himself. And so, this sort of helped, this was kind of the beginning of our understanding of the role of the prefrontal cortex in the brain. What was called the American Crowbar case at the time inspired a lot of research looking at both human cases of frontal lobe and prefrontal lobe injury. And then also people were kind of looking at, doing some animal studies, looking at monkey, resecting monkey prefrontal cortices. Sort of historically, this was around the time, it was only pretty recent at this point that people had even come to accept that different areas of the cortex had specific functions. So the ones that were known about at the time were the primary motor cortex, you can see here red, Broca's area, which had come after Paul Broca, a neurologist, had published on his patient who had had a stroke in that area, that left frontal inferior area, and then was really unable to produce words. And so that's, we know that aphasia is related to injury in this area sometimes. But there was still this kind of big question mark about what's in front of the motor cortex, nothing important. And so this case really showed that, in fact, there is important stuff that happens there. We sort of, it plays a role in a lot of things. And so, and we now know prefrontal cortex is extremely important for normal cognition and behavior. This is just kind of a selection of different papers and articles that are kind of talking about the prefrontal cortex. I just really like this one in green. It's the prefrontal cortex, center of the universe, right? So it's sort of, we've gone from thinking it doesn't do anything to thinking this is really where the seat of the sort of the true person is. The injury here can really just fundamentally change how somebody is. So I thought we'd do a little neuroanatomy lesson here, just to understand the areas that we're talking about. So here on the left, you have what I'm showing you, the dorsolateral prefrontal cortex. This is primarily involved in planning and organizing. So sort of has different functions on the left and right side. Incidentally, the left dorsolateral prefrontal cortex is when that area is, it's believed that some dysfunction in that area might be related to depression. And so when people get transcranial magnetic stimulation for depression, the stimulation site actually is left dorsolateral prefrontal cortex. And that activating that site appears to improve mood for a number of people. Here, this is kind of what we call the medial surface of the prefrontal cortex, or the inside, is the anterior cingulate cortex. And this area is involved in a circuit that drives initiation and motivation. And it's obviously very important for kind of pursuing goals. And then over here, the orbitofrontal cortex, so the kind of inferior surface or the sort of like underneath the surface, or right behind the eyes, essentially, is involved in inhibiting behavior you don't want to come out and regulating emotions. And so these three areas, they work together and they send pathways, circuits that kind of run through into kind of deeper gray matter areas in the brain, basal ganglia, and thalamus, and then kind of loop back up. And so, the normal functioning of these circuits is important for normal behavior. So, Phineas Gage's injury was very focal, right? Sort of was this rod, it went right through this kind of particular area, and then came out. But how else can trauma damage the brain? So that actually, we would call that now a penetrating traumatic brain injury. Most commonly now we would see that, we see the gunshot wounds, and or kind of other things that can go into the brain. And but this is not the most common type now. And really, this is it seems obviously it's not good to have a bullet go into your head. And so it depends on kind of where the path of the projectile or whatever has gone into your skull goes. But, in some ways, this type of injury it's kind of less messy because there is just this kind of like very narrow path. And, everything else around is sort of left untouched. The more common type of injury that most people, nowadays will experience if you have a TBI is what's called non-penetrating or closed head injury. And so this is essentially where, you're sort of either you're moving and something you hit something stationary, or you are stationary, something moving hits you. Typically what's involved in this is what's called an acceleration deceleration injury, where you're moving and then something stops. And so there's this kind of like ricochet effect inside the skull, and the brain kind of bounces back and forth. There is also, depending on what, the type of injury and, kind of what the mechanism of the injury is, how fast you're going and things like that, there can be some shearing or torsion effects, so kind of twisting around some of the pathways in the brain. And so the more of that there is, the more severe the injury is. That tends to be more of an issue with kind of high-speed motor vehicle collisions and things like that. And so this accounts for the majority of kind of civilian life traumatic brain injury. There is also blast injury that is like kind of a relatively newer category of traumatic brain injury that we now understand that mostly is military populations, or sometimes people who have been involved in sort of terrorist attacks and have been essentially near a bomb that went off, and there's this kind of pressure wave that sort of shakes up the brain tissue in this more diffuse way. And so, the physics of these injuries is kind of important because, in thinking about how people have, what kinds of symptoms come afterward. And so, part of the reason that traumatic brain injury is often separated out from all the other types of acquired brain injuries that I mentioned, in some ways, even though every injury is unique and everyone's brain is unique and who you are when this happens to you is very important, the kind of mechanism of traumatic brain injury is such that there are some areas that are just much more vulnerable, and it is much more predictable which areas are going to be affected. And so you can see here, just based again on that kind of acceleration, deceleration situation, the kind of these front aspects of the brain, the front part of the prefrontal cortex and the temporal lobes, sort of jam up against the skull, the kind of these like hard bony areas of the skull. And you get these areas of injury that are just kind of the characteristic injury distribution for people who've had a traumatic brain injury. So you can see here, much of it centers like in that prefrontal cortex area, and here in the kind of undersurface that we were talking about, the orbitofrontal cortex. And I just have here, to show you kind of, we know, much of our sort of normal brain function, we have a number of neurotransmitter networks. And so the nuclei for those networks live in typically, mostly in the brainstem. And so nuclei are kind of, groups of neurons that produce these chemicals that are important for signaling, and for sending, different kinds of messages to different places. And so, the ones that we think about commonly, serotonin, dopamine, norepinephrine, acetylcholine. We've heard these referenced. In much of our medications, especially in psychiatry and to some extent in neurology, are manipulating some of these neurotransmitters. You can see those pathways really overlap almost exactly with where these injuries are. And so, having this kind of injury can really just disrupt a lot of just important information processing. And so the prefrontal and temporal regions are the areas that are most injured in these injuries. Uh,
I ha
yes,
there's a question in the
yeah,
chat. Is it okay if I
yes.
ask? This is related to, I believe, slide 14, two slides
Okay,
back.
yeah.
Noah asks, if you have pain in one of those areas, even though the injury might have been to another area, is that indicative of anything?
So, a pain, like pain in like sort of a headache type pain. The injury, what I will say is that you can have the injury doesn't always cause pain exactly where the injury was, I guess. You might have like uh, you might have kind of outer injury, like to the skull or to your soft tissue. You might have bruising. That would be where the impact was. But then you can, sometimes, especially if, for many people who, like, as you saw, migraine is very common, one of the common neurological disorders we mentioned. And so if you have migraines before this accident, for example, and then you have a traumatic brain injury, you might have injury to kind of only one small area, but then, headache kind of everywhere in the head or in different parts of the brain. Yeah, so it doesn't always necessarily correlate to where the injury was.
Thank you.
That question. Yeah, please stop me anytime if you guys have questions. I don't mean to make an animation here. Okay. So again, I'm a neuropsychiatrist, so frequently I'm seeing people who are having cognitive or neuropsychiatric symptoms after a traumatic brain injury. And these symptoms typically are related to that frontal and temporal lobe injury. And just to kind of cover broadly, frontal lobes, we mentioned that, those areas that I talked about, the dorsolateral prefrontal cortex and anterior cingulate, and then the orbitofrontal cortex, collectively, they contribute to a cognitive domain that we call executive function. And so this refers to like a lot of different things, but overall includes planning, decision making, being able to choose your own goals and put behavior in place that that is able to pursue them and not get distracted. Be able to kind of like keep in mind something that you want to get done, and do that. Being cognitively flexible. So, sort of that's kind of the opposite of being, kind of pursuing a single task. It's being able to disengage from that when you need to, adjust your thinking and behavior in response to new information. And also impulse control. So kind of choosing how to react to a certain situation, kind of you can have an initial response and say, I don't know, this is not the appropriate, I probably shouldn't say that right now. That's executive function. Um, on the sort of this area of the temporal lobes, and that's that orange area down here. Temporal lobes are very involved in memory and emotional processing, and also language. I can say they both frontal and temporal are involved with language. But in particular, what happens here is kind of a regulation of the intensity of emotions, and this is part of an interchange with the frontal lobes, where the sort of temporal lobes, especially the kind of medial temporal lobes, the amygdala, in particular, is kind of at the sort of anterior aspect of the sort of most front aspect of the kind of inside part of the temporal lobe. It is very involved in the body experience of emotions, interpreting body input like your heart rate and kind of other body sensations, and how to make sense of that in terms of emotional situation. And also, as we know, we talk about this a lot in the Alzheimer's world. The temporal lobes contain the hippocampus. The kind of inside part of the temporal lobes contain the hippocampus, which are very important for memory. And so the temporal lobes provide memories. You make memories accessible for context. So when you're in a given situation, you can recall things that are similar to this and choose a behavioral response that is appropriate to the current situation. And again, this is kind of done in conjunction with input from the frontal lobes, which helps to kind of regulate. And so, if you have temporal lobe emotional activity that's unopposed by frontal lobe kind of top-down regulation, you might have these very strong emotional responses, be unable to sort of slow down or, kind of take a step back, even though it's not working well for you. And we do see this in some people who have had a traumatic brain injury, even milder ones. Sometimes this can be part of it, that people can say, I feel, not like myself. Like I'm having these strong emotional reactions, and I'm snapping at people, and I'm saying things that people regret afterward. And it's that kind of disconnect between being able to control, sort of being able to feel feelings and then also regulate them. That can be disrupted. This is not a talk necessarily about neuropsychiatric symptoms of Alzheimer's or other dementias, but just a point that when people do have, these neuropsychiatric symptoms are common in dementia as well. We understand now those are a core feature of Alzheimer's and other dementias. Sometimes they can start earliest, even before memory symptoms or other cognitive symptoms. And when there are these neuropsychiatric symptoms, the ones that are most bothersome, they typically also are related to involvement of the frontal and temporal lobes by the dementia. So I have a little bit here about just kind of defining the severity of traumatic brain injury. And this is, um, there's, maybe people have seen in the news, there's a lot of discussion of different kinds of traumatic brain injury. There's been a lot of debate about how to define this. And so, kind of a number of different ways of looking at this, but one of them is this is from the Department of Defense, which, because of the military involvement, there's a lot of interest in capturing this and a lot of research going into how to help people with traumatic brain injury. And so, in the mildest category to meet criteria for a mild traumatic brain injury, this is also known as concussion. And what's interesting is that kind of historically, the term concussion kind of was intentionally kind of brought back into circulation because the idea, when people were diagnosed with a mild traumatic brain injury, it just kind of felt worse than concussion. Now I think concussion is such a loaded term that sometimes that can be psychologically difficult. But so mild TBI and concussion are the same. And basically this refers to situations where you have had a brain injury, like something happened, you had a traumatic brain injury, there was some external impact, you had some experience that suggests there was brain dysfunction. So feeling dazed, you got your bell rung, sort of people will say like that visual symptoms, things like that, being off balance. Again, you are allowed to, you lose consciousness for a little bit of time. But the difference here is essentially the duration of symptoms and the fact that typically this is the type of situation where you go and you get, if you go to the ER for this, which many people do not, which is a whole separate sort of discussion. But if you go to the ER for this and get a, CAT scan of your head or even an MRI, it may look normal. And so, typically, like even if you've had a real concussion, you have real symptoms, you're feeling pretty bad, the imaging looks normal. It doesn't mean there wasn't an injury, right? It's just that we're not seeing it. Our tools are not sensitive enough to pick it up. So typically in this category of mild injury, the imaging is normal. You may have lost consciousness, but that would only be for the longest to be 30 minutes. And then you might, after, say you lost consciousness for a few minutes, if you wake up from this, you might be not quite yourself or be confused or not sure what's going on for up to 24 hours. And also, during that period of time, you might have difficulty making memories. And so that is related again to that temporal lobe involvement by the, sort of the traumatic brain injury, that the memory circuits essentially get kind of transiently disrupted. And so this is a very, the sort of recovery period from any kind of traumatic brain injury, whether mild, moderate, or severe, sort of follows a very predictable trajectory, and it's really just the length of time people stay in those stages that kind of dictates how severe we call it. But there is this period after a brain injury, a traumatic brain injury. It's called post-traumatic amnesia. Other people call it a post-traumatic confusional state. But the sort of defining characteristic is really that people, that you would have trouble kind of consolidating memories, and so you'll be told something, and then a few minutes later be unable to remember that. And that should go away for a mild injury within a day or less. And historically, these injuries, the severity used to be evaluated using what's called the Glasgow Coma Scale. And so this is more of like in the emergency room, the ER doctors, the trauma surgeons, the neurosurgeons might be doing this scale. And basically it looks at, kind of, it's a very sort of, it's looking at basic function of, eye opening and, how much you're able to speak and how much you're able to move. And there are sort of levels of complexity. So if you are opening your eyes spontaneously, and you are, moving everything kind of purposefully, and you are, verbally communicating in a way that is appropriate, that'll be your full score. As you go down sort of in those categories, people may be, maybe they move when you kind of ask them to or sort of stimulate them, but they're not, kind of moving on their own. So things like that. So this scale historically was used to gauge severity, but is no longer really considered to be the best scale because it really misses a lot of other aspects of the injury that might be pretty severe. So, I was involved with a case one time of someone who had fallen like from like 20 feet. And he fell on his head and sort of had all these had bleeding in his brain, had all these injuries, had to have surgery. It's a whole complicated thing. But his Glasgow Coma scale at the time, his initial score was like 14 or 15, very good. And because of that, he was kind of trying to get disability and there was a lawsuit and all these things. And I think the opposing side was saying like, well, this is not really, it's a very mild injury because of the scale. And so, we don't really use, that scale is not everything. In the moderate category, that would be you lost consciousness maybe for longer than half an hour, less than 24 hours. You might be confused for longer than a day. And you might be longer, you might have a period of time longer in that, period of time where you're the post-traumatic amnesia, where you're having difficulty making new memories and retaining them. And this again, sort of, there are a lot of kind of debates about the length of time and all these things. But essentially, this period of post-traumatic amnesia probably is the strongest predictor and strongest indicator of the severity of an injury. And so, you can have, you might have that, a short period of that after a milder injury. You might have a much longer period of it after a severe injury. And in the acute rehab setting in the hospital, we work with people who've had a severe injury. Often people are in this, people can be in this period for many weeks, post-traumatic amnesia. And then, at some point it clears. And then you kind of, it's sort of you're back online. And what's bizarre, I think the sort of experience of living with that is, the period of time that you were in post-traumatic amnesia, because you weren't making memories, those memories they're just not there. And so often it can feel like, oh, I was in a coma for 3 months, but it might be that you were awake kind of in this period. But so we look at the length of that period as an indicator of also how severe the injury was. And so, in a lot of TBI, traumatic brain injury literature, mild traumatic brain injury is distinguished from moderate to severe. We do know that the severity of injury, sort of as the severity of injury goes up, some of the potential for the complications that I mentioned, neuropsychiatric symptoms, and also that sort of increased risk of dementia down the line that also is higher with moderate and severe brain injuries. It has not been really demonstrated for mild, but that question is still open. So again, the moderate and severe TBI are generally more obvious. This mild TBI or concussion is kind of a continuously evolving concept. It can be pretty subtle and hard to diagnose, but it's a major public health concern. And so these are just from the Department of Defense, again, looking at numbers for traumatic brain injury. Mild TBI or concussion accounts for the vast majority of these. And what's difficult in evaluating sort of prevalence and looking at the kind of demographics of TBI is that many people who have had a concussion, they don't go to the hospital, right? So how do we, they don't see a doctor. They just kind of move on, or maybe they have headaches or they feel bad for a week or so, but they don't kind of, we don't know about a lot of the people who this is happening to. And so, some of this body of research is really kind of trying to identify people who, maybe had this kind of injury, but didn't necessarily seek medical care, and kind of what their outcomes are. And it's just a point, in the news, maybe you've seen some of these things. These are kind of different, the full spectrum of brain injury. And so, we now know these kind of blast injuries, that people are experiencing, and also people who have had these kind of chronic, this has been very much in the news, this CTE, right, chronic traumatic encephalopathy. And that refers to a very specific disorder that in some people, it seems, who are exposed to multiple concussions. And also now the idea is that there might be some what we call subconcussive impacts, sort of injuries that maybe didn't register as a full concussion, but still potentially were, caused some injury to the brain. That, being exposed to a lot of those over time is not ideal. And some people develop abnormal deposition of tau proteins and sort of other kind of have other inflammatory and neurodegenerative markers that then can progress into this syndrome CTE that often comes with cognitive impairments and mood and behavioral changes. And so this is a big area of research right now. Anyways, this is again sort of CTE is different from normal concussion, is different from most kind of the typical kinds of TBI that we're talking about. This is a very sort of particular type of injury, of cumulative injury that happens over time, and we're kind of still learning about it. So just kind of thinking about normal aging, TBI, and dementia risk. So, when we think about traumatic brain injury, and this is true even in the medical setting, I think like when I was in medical school, it's how we kind of thought about it. But, people often think about like young people in car accidents or motorcycle accidents, and that is some of traumatic brain injury. But actually, the largest category now is adults over 65. And again, we are limited by the way that the data is obtained. And so, if we're looking only at people who go to the ER, are hospitalized, or who die from a traumatic brain injury, the largest category now is adults over 65. And the most common cause is falling. And often that is from standing height. That is the most common sort of mechanism for this. And, what is complicated is that people who fall, there are kind of a lot of things that go into whether a fall is really problematic for you. And so older adults in particular, people who are on, multiple medications, who might be, sort of your balance might be off, or if you're taking blood thinner medications, that's why we think a lot about fall risk, because we really don't, if you're having trouble with balance and you're taking blood thinners, if you fall and hit your head, you could have much more bleeding into your brain, than you would without the blood thinner. And so that is something we worry about. Changes over time just with normal aging. There are changes in mobility, coordination, and that can obviously be worse if you are living with something like Parkinson's or kind of other things that can impair mobility. Again, as in medical illness, and particularly this idea of polypharmacy, which maybe, if anyone has seen this, it is in the U.S. healthcare system. Often there is an interest in just, prescribe medication, try to help you with this thing, with your problem with this medication, and people end up on like, 10 medications. And so there are a number of studies that show that really once you get beyond like 3 or 4 medications, and you start to kind of have this problem where, they can be interacting. Often, as doctors, and I'll include myself in this, I think we're not always great about de-prescribing. Like that's why geriatricians are wonderful. This is their thing that they do. So if you're seeing any of the geriatricians at Barlow, they're awesome. And, this takes time to figure out what people really need. Why are you on all these things? But it's very important to do that, to continually reassess medications and whether you need them all, because, having multiple, kind of does put you at risk for having things happen. And then cognitive impairment, as I said, so, whether that's neurodevelopmental or something that has developed later in life, we know that people who are cognitively impaired and people who have dementia, from Alzheimer's and other types of etiologies, are at risk for falling and potentially developing a traumatic brain injury. So, there are kind of 2 types of TBI or traumatic brain injuries that can happen, or sort of the impact of TBI in older adulthood can be you were over 65 and had a traumatic brain injury. And so in some people, that does seem to, it may accelerate cognitive decline for some people. In people who have a traumatic brain injury in younger adulthood, again, as I mentioned, that used to be thought of as kind of like a that's a thing that happened and put you at a, sort of that's a fixed entity, and now we're not expecting it to progress. But in some people, it does interact with the normal aging process, and so may increase dementia risk for some people. The ApoE, if you guys are familiar with this probably from your research participation, but the ApoE4, apolipoprotein E4 allele, which we know increases risk of Alzheimer's. It also does increase risk of traumatic brain injury related cognitive impairment. And so that may be some of the interaction there. We also know that with more moderate to severe traumatic brain injury, we're still looking at this for mild, but in moderate to severe injuries, there is actually accumulation of amyloid protein in the brain. And so, obviously amyloid is very famous in Alzheimer's world. We're looking for it all the time now with scans and, ideally, now we have the MRI and not, you don't have to do spinal taps all the time and possibly blood testing, but in people with traumatic brain injury, there can be this, in most people, transient accumulation of amyloid. And so it seems that, amyloid may be playing some kind of protective or healing role or something. But there is something about, in some people, again, might be kind of the apolipoprotein or many kind of potential, genetic and other contributors that some people, most people clear out that amyloid, and it does not necessarily have anything to do with developing Alzheimer's later or really cause any problems. But some people, the amyloid continues to accumulate. And just a point, again, about, having amyloid, if you have amyloid in your brain, that does not mean you have necessarily Alzheimer's. We're sort of figuring out, there are some people who have amyloid deposition who don't, have a dementia diagnosis and don't have dementia symptoms. And so, this is all sort of, some of this is still being investigated, but the sort of question of what amyloid is doing in traumatic brain injury and how it interacts with cognitive impairment later is kind of it's a hot area in TBI right now. And so I'll just close with, there are things that we can do. And, I think the important thing I do want to say is that most people who have had a traumatic brain injury are not going to develop dementia. This is just kind of, we're thinking about risk, sort of, increase or decrease risk. But, this is not the majority of people, but it is a potential risk factor. And so, but things you can do that really help with both of these illnesses. So staying physically active with regular exercise, especially cardio. So walking and running. Is just very good for, or anything gets your heart rate up for a little bit. It's just very good, particularly for those memory circuits and just for, kind of brain health. It sort of helps to maintain brain volume. And also as since we talked about the falls being kind of the primary potential cause of traumatic brain injury, sort of anything that is improving your balance, coordination, making you more mobile, that's great. We like that, is protective. Staying mentally active. So cognitive reserve, we know, is a protective factor. So, kind of, and that includes staying socially engaged, doing things you enjoy, having hobbies. Like this is all, things that just kind of continuing to engage with people and sort of, and, reading and things that you like doing. Doesn't have to be just, sort of like crossword puzzles, Sudoku. It can be things that you like. Well, if you like those are good too. Having a healthy diet, so mostly plant-based, really keeping minimizing red meat and processed foods, not limiting refined sugars, all the things that go into healthy kind of heart health, and if you have diabetes and managing that, making sure that blood sugar is regulated. Again, these are all going to be protective for both of these problems. And again, if you have one of these diagnoses, keeping up with medical appointments, and as I said, like neuropsychiatric symptoms are real, and this is, it's not a personal failing to be depressed or to have, kind of changes in mood and behavior and things like that. And this is, these are things that we, can help with, and sort of addressing them actually can really reduce your risk of other things, potentially coming as a consequence. So, we would definitely sort of encourage that. I think that's all I have. Yes. So.